Okay, so speaking about the nephritic is a pathology of the glomerular basement membrane. So at that time, we used to lose RBCs into the urine, and yeah, that was pretty much it. But after some times, what happens? Your podocyte destroy as well. When that happens, you will have an impaired charge barrier, which lead to both hematuria. Why? Because of the glomerular basement membrane damage, and the proteinuria. Why? Because of the problem in the charge of the barrier. What is the normal charge of a glomerular basement membrane and the podocyte? What is the normal charge of your filtration barrier? Negative. I just want negative or positive. It's negative. Okay? So, nephritic nephrotic syndrome. So the nephrotic range proteinuria. I remember like someone once told me it's nephrotic. It has an O, so the O represents the O in the proteins. So remember, it has more proteins inside of it. So nephritic range proteinuria more than 3.5 grams per day, and concomitant features of nephrotic syndrome. So they have both nephritic and nephrotic syndrome. So the nephritic syndrome, they have the blood. Nephrotic syndrome, they have the huge amount of proteins. So they have both symptoms. It can occur with any form of nephritic syndrome. As I said, the itic can become otic, but the otic cannot become itic. So nephritic syndrome can become nephrotic syndrome, but nephrotic syndrome cannot become nephritic syndrome. It's common in the following: diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Now we are going to explain every single concept about these nephritic and nephrotic syndrome. Now a quick poll. Would you like me to do this topic from a 2020 first aid or a 2021 first aid? So 2020 versus 2021. Here you go. You choose. Come on. So counting to 10 to make the decision. 1, 2, 3, 4, 5. What is the difference? Well, basically, the old one, mine is annotated. It has some notes on it. The new one has no notes in it. Okay. Let's see. Democracy says the new one. Oh, changing my vote. I see. Okay. So, come on. Someone else vote. It's 50-50. Okay, let's just continue doing it from the old one. The new one does not have anything really different from the new one. So nephritic syndrome, the nephritic inflammatory nephritic, it's an inflammatory process. So what is destroyed in nephritic syndrome? Remind me, please. Was it the glomerular basement membrane or the podocyte? Where was the damage? Yes, it was the glomerular basement membrane. So the first condition we are going to speak about is something called acute post-streptococcal glomerulonephritis. So I know why students hate nephritic and nephrotic syndrome. They are not difficult, but they hate them for only one reason. This reason: electron microscopy. You're like, wait, what? Do we have to know electron microscopy? Yes, we do. Is it that difficult? Not really. Why? Because I'm going to show you every single one of them and how to find out the correct answer. I hope that makes you feel better. So, acute post-streptococcal glomerulonephritis, it is most commonly seen in children. So why these children have it? It happens between 2 to 4 weeks after a group A streptococcal infection of the pharynx or the skin. So the group A streptococcus, also called Strep biogenes. Pretty soon we'll start microbiology. When we do, please be careful, because I want all of you to do sketchy sketchy. For those who don't have a sketchy account, let me know. I will figure out a way for you to get it. So sketchy, if we speak about Streptococcus pyogenes, which is also called group A Streptococcus, they show a lot of stuff inside of it. One of them, if you notice, yep, this guy, he has this thing on his neck. That thing represents pharyngitis. So if we go back to the first aid, they write, it's most commonly seen in children 2 to 4 weeks after a group A Streptococcus infection or of the pharynx or the skin. Keep in mind, this group A strep also led to something in the heart, if you remember. It led to heart inflammation, which was in case of rheumatic fever. But if you remember, in case of rheumatic fever, it was only after a pharyngitis, not after an impetigo, which is a skin infection. But the kidney can be inflamed after pharyngitis or after a skin infection, so both. The kidney is much more sensitive than your heart. So it resolves spontaneously in most of the children, but may progress to renal insufficiency. Yes, and it may progress to renal insufficiency in an adult. So they might give you two patients, or they might give you a patient and tell you what is the worst prognostic factor. If she was old or he was old, choose the age. If you are old and you get this, it's really bad. But if you are young and you get this, it's not a big of a deal. You must know how it happens. It's a type 3 hypersensitivity reaction. If it's type 3, is it antibody mediated or immune complex mediated or cell mediated? Immune complex mediated. Excellent. Remember, type 1 was an IgE mediated. Type 2 was antibody mediated. Type 3 was immune complex mediated. Type 4 was cell mediated. Okay. Well, what about vasculitis? Which type of hypersensitivity reaction it was? Vasculitis. No, it was not type 1. No, it was not type 2. Come on, you are going to choose all of them? It's type 3. It's type 3. Okay. So vasculitis is type 3. As you can see here, it's a type 3 hypersensitivity reaction. That was vasculitis. It presents with peripheral and periorbital edema. Guys, in case of kidney dysfunction, is the edema more in the morning or in the evening? It's in the morning. Why? Because you have not gone to the bathroom for all night long. So you have not gotten the fluid outside of your body yet. But if we speak about heart failure, is it in the morning or in the evening? Evening. Yep. After a long day of work. So they write it presents with a peripheral and periorbital edema and with tea or Coca-Cola colored urine. Well, let's take a look at that. I love looking at urine. That sounded bad. Post-Streptococcal glomerulonephritis urine. It looks actually dark, really dark. Look, it looks like tea, really bad tea that you don't want to drink. It's a blood, basically. Yep. Okay, and you can even here see this picture. Let me just copy this and send it to you. Yep, you can see even in this picture they are showing the RBC cast, yeah, and the patient has periorbital edema of his face. Okay, so next let's take a look here. So the patient has the following: tea or Coca-Cola or cola colored urine. He is hypertensive as well. Why? Because there is more renin secretion. So they ask you what is the cause of hypertension in nephritic syndrome. The answer is because of increased release of renin. Okay. There is a positive streptococcus titers and serologies. Remember, the titers include anti-streptolysin O, anti-DNase, anti-hyaluronidase enzyme. These three antibodies are present in case of strep pyogenes. So again, for those who did not get them, let me repeat them. They go something as follows. In the sketchy, they are represented by these three structures. So they are the anti-hyaluronidase, anti-streptolysin O, and anti-DNase. It's not anti-DNA, it's anti-DNase. DNase, why? Because anti-DNA is lupus. So this is DNase, it's not lupus. Okay? So pretty soon we'll start sketchy. Hyaluronidase. Let me show you how to write it. Person with dyslexia will write anti-hyaluronidase. This guy. You can, I will post it for you. They have this one. Here you go. So, the next one. So, in light microscopy, you will see a glomeruli that are enlarged with hypercellularity. So, let's take a look at them. So, this glomerulus have a lot of cells, but you are like, how can I tell that it has a lot of cells? I did not see a normal glomerulus. So, okay, that's fair. So, let me show you a normal glomerulus. So, a normal glomerulus histology looks something like this, okay? So yeah, it's true that it has a nuclei, it has cells, but not that many. But if you look at a post-streptococcal glomerulonephritis, and you take a look at the histology, it will be really hypercellular. Why? A lot of inflammatory cells are accumulating inside of it. So actually not all of these cells are the cells of the kidney. Most of them actually are cells of the immune system going there. So let me post this one. Sorry. As you can see here in the picture, there is what? Yeah, there is a lot of cells from the kidney itself. But notice there is a few nuclei that looks weird. They are not from the kidney. They are inflammatory cells coming to the kidney just because of the inflammation. So let's go back here. So yep. Going to the next question, you can see that the patient has a glomerular and enlarged, the glomerulus will be enlarged and it will be hypercellular, a lot of cells inside of it. But now comes the important stuff, the stuff that you will actually be asked about. This is stuff in the beginning nobody cares about, but these everybody cares about. But before going there, I want to show you one thing. You guys told me which type of hypersensitivity reaction is acute post-streptococcal glomerulonephritis. Type 3. Type 3 is mediated by immune complex. What is immune complex? Immune complex is three things. Antibody attaching to antigen, exactly. Attaching to a complement. Absolutely correct. So these are three particles. So what will happen to your complement level? It will go down, it will go down. Your complement will be consumed to make immune complexes. If you are making so many immune complexes, your complement level will go down. Because you are making so many immune complexes, you are consuming them. Okay, so they write decreased complement level due to consumption. To make what? Immune complex. Okay. So the next thing is about immunofluorescence. So in immunofluorescence, you are going to see a granular appearance. Why? Because it's immune complex. Well, before going there, I just want to tell you something. If you have immune complexes, one will attach here, another one will attach here. Another one will attach a little bit far away from it, like here. And like this, they will keep attaching. So you are like, okay, so why this is relevant? Notice, between every deposition and every deposition, there is a free space, yeah? So the depositions are granulars. So let's take a look at that. Okay, so you can see here, actually it's a really low quality. Let's do this. If you take a look, come on, yep. If you take a look, there is like little deposition, another one, little deposition, another one, little deposition. Exactly, I mentioned it in vasculitis to teach you the difference between them. But remember, in vasculitis, it was Bausi immune, which means it's neither granular or linear. It's neither, okay? It was black, ditch black. But you will see why I mentioned it in vasculitis in 5 minutes. So you can see here we have deposition, no deposition, deposition, no deposition, deposition, no deposition, deposition, no deposition. So it's a granular, yes? And when you see granular is equal to what? Is it immune complex or antibody? Immune complex, yes, it's immune complex. So immune complex, it will lead to, it basically will lead to granular. So granular is equal to immune complex, okay? So let's now try to speak about the other one, which is antibody mediated. By the size, which one is smaller, immune complex or antibody? Antibody, obviously. So millions of little antibody will be accumulating here. So the spaces between these minor antibodies will be super small, and they will be just accumulating all over this area. Yeah, so they will create a linear form of deposition all over here. So that linear deposition can be seen on linear microscopy as well. So I just want to show you a linear immunofluorescence. Okay, so since it's linear, it's continuous. As you can see here, the accumulation are continuous with each other, not granular. So they keep going. One more picture, it keeps going, keeps going. So let me send you this one. So this is linear. Someone can just like forward it and write on it like this is a granular and this is linear, just for the future for people to see it. Okay, so the third one, it's when there is no accumulation at all. There is no antibody accumulation, there is no immune complex accumulation. We call it Bausi immune, okay? So Bausi immune looks something like this. It's Bausi immune, it means it's Dutch black. You cannot see anything. Okay, so now comes the question, why did we study all of this? What is the difference? What is the importance of these? And why we have to differentiate between them? Isn't there a more convenient way? Well, it's more expensive. This is much cheaper, but let's speak about the most expensive method in a moment. So in electron microscopy, now we are speaking about acute post-streptococcal glomerulonephritis. So since it's acute post-streptococcal glomerulonephritis, a type 3 hypersensitivity reaction, will it be granular or linear? Think about it. It's immune complex. Okay, granular, because it's immune complex. Okay, that's good. So now we can keep going. So if a status granular appearance, also called lumpy-bumpy, so that was quite lumpy-bumpy, going up and down. It's due to an IgG or an IgM or C3 deposition along the glomerular basement membrane and mesenchyme. Basically, it's like an antigen together with an antibody and a complement going together, making immune complex and depositing on the basement membrane. So here we have the linear pattern, and here we have the immune complex accumulations far away from each other. So these lead to lumpy-bumpy and this lead to linear. Okay, so the next thing you must know, it goes something like this. Electron microscopy. You are like, damn it, electron microscopy? We really have to do this in USMLE? Yes, but I don't want you to be over worried about it. This is the only topic in the whole book in which you will need electron microscopy. So let's take a look at electron microscopy. So electron microscopy and post-streptococcal glomerulonephritis. Yes. So let's take a look. Okay, so first of all, before we take a look at it, I just want you to be comfortable with one concept. If we speak about the basement membrane, at one area it will have the podocytes, and at the other area it's going to have the what? The endothelial cells. So the endothelial cells are near the area where is the vessel located, where is your blood going. And the other area is the podocytes, where it's near your Bowman's capsule, basically, yeah? So if you take a look at it, the deposition, there will be deposition. We can say either they are endothelial when they are under the endothelium, or subepithelial when they are under the podocyte. So remember when I told you that the podocytes are considered epithelial cells? Now comes the importance of that. When we say the accumulation of subepithelial in the kidney, it means they are under the podocyte. Okay. Now let's go back here. Yep, now going back to electron microscopy. So, first of all, when you take a look at the electron microscopy, it looks weird, you know, it's not something that you are really used to take a look at and be comfortable with. So, first step for you is to take the picture, put it in front of you, and start making sequential line on it. So, let's make some sequential line. Okay, so starting with delining the basement membrane. See this line here? This is the basement membrane. How do I know that? Well, it's homogeneous. It looks similar to each other because it's made from which type of collagen, this basement membrane, guys? Can somebody tell me? Yes, it's type 4 collagen. Okay, so you have successfully detected what? The basement membrane. Excellent job. Your next thing to do is to be able to detect which area is the vessel, which is like inside of your glomerular capillary, and which area is the Bowman's capsule. Guys, the podocytes is the basement membrane from the tubular. No, it's like a sandwich. Remember, it's like a sandwich. So if the basement membrane was here, the podocyte will be from one area and the other side will have endothelial cells. So the basement membrane is like a sandwich between two layers, okay? So the first layer, you need to detect which layer is where. So I told you one layer is the epithelial cells, which is the podocytes. Podocytes from one area and endothelial site from the other area. The endothelial site, is it near the Bowman's capsule or near the vessel? The endothelial site. Endothelial layer. Yes, it's the blood vessel. It's the blood vessel, exactly. So a blood vessel normally has cells inside of it, correct? And has a lot of fluid and a lot of stuff inside of it. Also, an endothelial cells, it's a cell. It has a nucleus, correct? Okay, so you successfully detected what? Basement membrane. Excellent. Your next step is to detect what? One of the two. You either have to detect an endothelial cells or you have to detect a podocyte. A podocytes have what? Slits, yeah? So I don't know how can I zoom in. Well, anyway, so you can see these little slits here. If you can appreciate, they look like this. See? These little slits. So this area in blue is what? With the little slits. What do you think the area in blue is? It has exactly, it's the podocyte. It has the little slits. Okay, now I'm going to give this color. Now in this area, there is some opening, which I will not tell you what it is yet. But if you notice, it has here, there is a big nucleus which represent an endothelial cells nucleus. So if endothelial cells is here, what is this layer? The endothelium. So endothelium, basement membrane, and podocyte. Okay, so that's norm. Let me send it to you. Now we are going to speak about the pathology. Let's speak about the pathology. There is deposition in this picture. Well, where is the deposition? If you enlarge good enough, there is a black here. If you see the black near the star, there is a black. And the black is going under which layer? Is it under the epithelium or under the endothelium? No. We compare it either under the epithelium or under the endothelium. It's going under the endothelium because the basement membrane is over it. It's preventing it from touching the epithelium, which is the podocytes. Yeah? So it's subendothelium. Since it's subendothelial, you are like, subendothelial. Sounds familiar. Okay, let's open first aid and see what is subepithelial and what subendothelial is. So here, the one you just saw, this is actually not post-streptococcal glomerulonephritis. Why? Because it's subendothelial. It could be lupus, for example, but it cannot be this one. So now, let me see. Okay, this one is perfect. This one is perfect. Oh. Okay. And edit. Okay, so if you take a look at this one, first step when you look at electron microscopy is to detect which structure. Basement membrane. Let's do it. This is our basement membrane. Okay, you detected the basement membrane. Your next step is either to see the podocyte or to see the endothelial cells. I prefer to search for the podocyte actually because they are much more easier to detect. So here they are, podocytes. Yep. Okay, so podocytes are here. Excellent. So they are, and this is actually the podocytes. These are just its slits. Okay. And here you can see some form of a mass that is unknown. We don't know what that is yet. Let's make it in green. There is some accumulation here that we have no idea what it is. We don't know. Okay. So, and then we are going to look up inside of this area. There is basically a lot of garbage here. Okay. But what is something you can appreciate and that you can actually see? There is a few nuclei here. Let me make it in yellow. There is a few nuclei here. They look like various blood cells, yeah? But like for example, if you enlarge, you can see like a red blood cell here. You can see a lymphocyte there. So it's kind of like a blood vessel, yeah? And even it has this endothelial cell here. So the accumulation obviously is the black stuff here. Since the accumulation is there, okay, accumulation is there. It's going under the what? It's under something, under this guy, which is what? The epithelial cells, the podocyte. So we consider it to be subepithelial. Subepithelial. This is the epithelium and it is subepithelial. Yes? Here you go. So this is a subepithelial deposition. When you see a subepithelial deposition, this is a post-streptococcal glomerulonephritis. Let's do one more just to be comfortable with it. Yes, this one is post-streptococcal glomerulonephritis, this one. Okay, one more time. First step to look at electron microscopy, what do you check? Okay, basement membrane, let's do it. Here is the basement membrane. Our next step to deal with it is to look for either the podocytes or you want to look for the endothelial cells. Well, here it's actually kind of really easy to see the endothelial cells. See this one? This is a nucleus of endothelial cells. Okay, what about just a second. Yeah, what about the slits? Well, there's a little slit here. There is a little slit here, 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 and little ones here. Yes, it's going even like there is this one here, this one going like this, and even something like this. Okay, so the deposition here are subepithelial. Excellent. Which is under the podocytes. So you see this picture, you are like, okay, this is subepithelial, so this must be which pathology? Post-Streptococcal glomerulonephritis. But it's a sign, not a diagnosis. That's the thing. In real life, you never do it. But for the sake of exam, you will be asked about it. That's why I explained it. So remember, the patient on the main thing that in case of light microscopy, the patient had nothing. He just had hypercellularity. Why? Because a lot of inflammatory cells went to that area. Okay, so the next pathology is something called rapidly progressive Crecentric glomerulonephritis. You are like, okay, well, what is a Crecentric? Well, a Crecentric, it's the form of the shape of the kidney. I hope they have a picture of it. Oh yeah, here it is. Okay, can you see the crescent here? There is a crescent. And that crescent actually is super important because they will ask you what it, oh, wait a second. Before I speak about the crescent, guys, in first aid, this immunofluorescent, is it a granular or linear or bouncy? Don't read, just, yeah. Excellent, it's a granular. You get it. So it's immune complex or antibody mediated. Immune complex, excellent, good. Okay, so let's take a look. So we have the rapidly progressive crescentric glomerulonephritis. Basically, the kidney will have a crescent inside of it. And actually, let's take a look at that crescent because, you know, kidney is all about saying so many videos, so many photos. And the more photos you see, the more comfortable you become with it. So you can see here, you can see the crescent just right there. Okay, so here we go. Here is a crescent. So this is a crescentric form of glomerulonephritis. Okay, you are like, well, this crescent is kind of hard to detect. I agree. But like after doing enough of these questions, it becomes just a second nature to you. So let me just do one more. Even here it has a little bit. Actually it's just like a bit of sclerosis there. Okay, so let's take a look at what first aid says. It says, rapidly progressive Crecentric glomerulonephritis. The moment you see it, it's really bad. Poor prognosis, rapidly deteriorating renal failure within days to weeks. The patient will die. You must know what are the crescent made out of. So in light microscopy, as we just saw, crescentic moon-shaped, which is like this moon-shaped thing we just saw, this crescent. And the crescent consists of fibrin and plasma protein, the C3b, with the glomerular parietal cells, monocytes, and macrophages. They love to ask about this. You must know that it contains a lot of fibrins and macrophages inside of it. The other one you are allowed to forget about, but the fibrin and the macrophage you are not allowed to forget about. They ask it a lot, okay? So you must know that inside of the crescent there is fibrin, there is like macrophages, and macrophages and monocyte. What is the difference between macrophages and the monocyte actually? Can somebody tell me? What is the difference between them? Monocyte, macrophage, they sound similar. Okay, when a macrophage is inside of a vessel, this is a blood vessel. If you have a blood vessel, If a macrophage is inside of a blood vessel, you call it a monocyte. The moment it moves from the blood vessel and enter the interstitium, you call it a macrophage. Okay? So that's the only difference. Okay. So the next thing is several disease processes can result in this pattern, which may be delineated via immunofluorescence pattern. Starting from the first one, linear immunofluorescence. You guys tell me if it's linear, is it antibody or is it immune complex? Antibody, excellent. So it's due to antibody to the glomerular basement membrane and alveolar basement membrane. If you remember, I told you about the good bastard syndrome, that good bastard not being so good. He has two guns, yeah? And he is firing what? Antibodies. And he's firing against the kidney and against the lung. The basement membrane of the kidney, the basement membrane of the lung. Okay. So that was good bastard syndrome. Remember that in good bastard syndrome, since it's a nephritic syndrome, there will be hematuria because you are destroying the glomerular basement membrane. That's what nephrotic syndrome is. And hemoptysis. Let me ask this. Will this patient have a cast in his urine? Of course he will. Of course he will. Why? Because it's an upper kidney problem, glomerular problem. Okay, it's a type 2 hypersensitivity reaction. Remember the Basta? He has two guns. He was shooting antibodies. And antibodies without immune complex, this is a type 2. The treatment is to get rid of these antibodies. How can you do that? With the plasmapheresis. Okay? So the next one, leave it for the ending. Leave it after we finish the granular. So the granular immunofluorescent is in case of post-streptococcal glomerulonephritis, which we just spoke about, or diffuse proliferative glomerulonephritis, which we are going to speak about in a minute. So in these two cases, you will have a granular deposition. Since you have a granular deposition, which type of hypersensitivity reaction it is? It's type 3, so it's immune complex or antibody mediated. Immune complex, excellent, good. So they write, here you get this one. Let's speak about the Bauce immune. So I told you previously about this one. I told you that there is no deposition, no immunoglobulins, no complement, nothing. Now, don't get confused. I will explain something. I did explain it previously, but I will do it again because I told you I will do this 3 times. Now the second time. If you did not get it the first time, try to get it this time. If you don't get it this time, you have one more chance to get it. So it goes something like this. This is Bauce immune, and it's caused by Wigner and Church-Strauss and microscopic polyangiitis. These diseases are all vasculitis, and vasculitis is because of which type of hypersensitivity reaction? Type 3, yeah. And it's due to immune complex, yeah? If it's due to immune complex, why it's not the granular? Well, here's the thing. The problem in this disease, it's a vasculitis, so it's an inflammation of the vessel, okay? So this inflammation is inside of the vessel, correct? So it's inside of the vessel and it will not escape the vessel. Your glomerulus will be here. But the inflammation is not in your glomerulus. The inflammation is inside of the vessel, vasculitis. When this vasculitis occurs, it will lead to acute inflammation that will destroy anything locally to it. But the destruction will be because of the acute inflammation, not because of the vasculitis, not because of the immune complex deposition. So after the immune complex has deposited here, he will start calling neutrophils and other inflammatory cells to burn out this whole area. When they kill everything in this area, they lead to a form of what? Destruction of your kidney, which is a form of a glomerulonephritis called rapidly progressive Crecentric glomerulonephritis. So in another word, vasculitis causing in Wigner, Shirk-Strauss, and microscopic polyangiitis. Yes, it's a type 3 hypersensitivity reaction, but the deposition will be in the vessels, creating local inflammation that will destroy the kidney. Okay? So they write, negative aminofluorescence, pauci-immune, and it will be seen in a granulomatosis with polyangiitis, which is Wigner, which was a C ANCA, and eosinophilic granulomatose with polyangiitis, which is Shirk-Strauss, or microscopic polyangiitis, which is a B ANCA, or myelobroxidase ANCA. Okay, so the next thing you must do is diffuse proliferative glomerulonephritis. So what is diffuse proliferative glomerulonephritis? So it's lupus, okay? It's always lupus. So it's often due to lupus. Think wire loops. We'll speak about the wire loops in a second. So they write here, diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. We saw these two near each other before. We saw it here. They were the nephritic syndrome that can become nephrotic, yeah? So they write, it often presents as a nephrotic syndrome and nephritic syndrome concurrently. So in this one and one more we are going to speak about, these two syndromes have both nephritic and nephrotic in the same time. So in light microscopy, you will see what? The wire looping. They show a picture here in first aid, but I really don't like it. So I would like to show you something more clear in Google, just a second. So on light microscopy, you will be able to see the wire looping. Okay, so let's take a look. Okay, so you can take a look here. Yeah. Okay, come on. So basically there is this little creation of wires here, a wire-like structure. You can see one more here. This is called wire looping, okay? So you can see it here. Yeah, good, it enlarges. So you can see the wire looping here. You can see it here, and you can see it here. So that we call wire looping. If you see that, it's lupus. Okay, again, one more. So, okay, I like this one. There is wire looping here, wire looping there, wire looping there. Remember, it's the white area, not the pink area. That's the wire looping. So, it's here, here, and here. That's wire looping. The moment you see the wire looping, you think about what? Lupus. It's always lupus. Okay, one more wire looping for the team. As I said, kidney is all about seeing so many pictures. Wire looping here, wire looping here, wire looping there. Yes, it is. Okay. So, the next thing, come on. I stopped it accidentally. Just a second. Just a second, I don't wanna. Okay. Okay, guys, let's take 10 minutes break. Just I need to fix this technical issue and we can keep going.